So this is part 2 of urinary system, part 2 of chapter 17. And now we get to talk a little bit more about these mechanisms of secretion and reabsorption happening within the kidney. So remember, this is where we're looking at the co-transport of glucose with sodium. This is an example of secondary active transport. So in this example, we have a high amount of sodium in the lumen of the kidney tubule, so in the urine. And we have an artificially low sodium amount then in that basolateral membrane. And the reason is because we've got these primary active transports pumping sodium into the blood, creating a low level of sodium in the basolateral membrane. So then sodium can diffuse down its concentration gradient from the lumen of the kidney tubule into the basolateral membrane, bringing glucose with it. And this is one way in which your body reabsorbs glucose and sodium. Okay, so glucose, to be reabsorbed, it's co-transported in the tubule cell with sodium. So there's no direct ATP needed. But it's still called secondary active transport because it relies on the action of the sodium transporter to pump from the basolateral membrane into the blood. These transporters have a maximum of about 375 milligrams of glucose per minute. And beyond this max, glucose then is excreted in the urine. So here's why you can see if somebody's not reabsorbing all their glucose or they have a lot of glucose in the urine, like is the case of diabetes, then they're not going to be able to reabsorb all of it, and then we'll be able to measure it in their urine output. Potassium is actively reabsorbed in the PCT, and chloride passively moves with sodium. Okay, so that potassium mechanism in the PCT is going to be a pump that's using ATP to actively reabsorb, and chloride is going to move passively with sodium. Urea is also passively reabsorbed from amino acids because when water leaves, the urea concentration increases, and so urea can leave passively. So about 50% of urea is reabsorbed, and we can measure this with the blood urea nitrogen, or called the BUN test. And creatinine from creatine phosphate is not reabsorbed, so we're going to be able to measure this in the urine all the time. But this could also indicate some changes happening in the body because we know it's not going to be reabsorbed. So it's a pretty reliable indicator of kidney output then. Let's think about this example. In diabetes mellitus, patients present with glucose in the urine and polyuria, frequent urination. In normal patients, no glucose is found in urine. So knowing that glucose is reabsorbed in the PCT and the loop of Henle functions via osmosis, why is our diabetic suffering from polyuria? Okay, so think about that. For an answer, come talk to me in office hours. Okay, so now we have to go back to our mechanisms of aldosterone. And aldosterone first came up, we talked about blood pressure because this is all really related, right? There's a constant amount of sodium reabsorption in the PCT and the loop, but we can get extra reabsorption if aldosterone is released from the adrenal gland. Okay, and so we talked about this in the blood pressure lectures. We said that aldosterone is going to be released from that renin-angiotensin-aldosterone system, and that's going to cause an increase in blood pressure. Well, how is it going to do that? It increases permeability of the distal convoluted tubule to sodium. So if it's increasing permeability of this distal convoluted tubule to sodium, we get more sodium reabsorption, and then water is going to follow sodium. That will increase blood pressure. Another hormone that came up in our blood pressure lectures that we'll talk about again now with the kidney is that ANP, atrial natriuretic peptide. And remember, this is the opposite. It's released when blood pressure is high. And so its mechanism is to decrease permeability of the DCT to sodium. And so you get less sodium reabsorption. So you pee out more sodium and thus you pee out more water, and that will lower blood pressure. So it encourages diuresis. It encourages urination. During a lifetime, human kidneys filter over 1 million gallons of blood. Okay, and so now we're going to talk a little bit more about this renin-angiotensin pathway that we first came across in the blood pressure lectures. So remember that this is a pathway to increase blood pressure and release aldosterone. And so aldosterone is the release of this, is the end result of this system, but it has a bunch of other functions as well. Okay, so in response to low blood pressure, you're going to activate this renin-angiotensin pathway. And this is happening because the kidneys are actually monitoring blood pressure. Okay, so we have this region of the juxtaglomerular apparatus here called the JGA, juxtaglomerular apparatus. And in that region, there is this tissue called the macula densa. And together, the macula densa cells of the thick ascending limb and the granular cells of the afferent arteriole make up this juxtaglomerular apparatus, okay? But you can look and see where it's essentially the junction of where you have some tubules and some blood vessels. Okay. And in these granular cells of the afferent arteriole are blood pressure detectors. So the granular cells detect blood pressure change. And if blood pressure decreases, those cells will secrete more renin. If blood pressure increases, they secrete less renin. The macula densa cell's job, then, is something a little bit different. So these cells come into contact with the granular cells of the afferent arteriole, and they monitor sodium and water concentration, okay? So the granular cells are monitoring blood pressure. Macula densa cells are monitoring NaCl and water. And these are related, but they're different, right? So of course, if you have more sodium and you have more water, you're going to have a higher blood volume and higher blood pressure, but they're not exactly the same. Because in addition to having to have homeostatic blood pressure, your body needs to have homeostatic levels of sodium and chloride and water, okay? So in the macula densa cells, they monitor the sodium, chloride, and water concentrations, and if these are elevated, your macula densa cells will constrict the afferent arteriole to maintain glomerular filtration rate, and tell the granular cells to slow down secretion of renin. So they work in concert, right? If sodium chloride and water levels are elevated, that probably also means your blood pressure is elevated, okay? And remember, when your blood pressure is elevated, you're going to have decreased secretion of renin from the granular cells also. So they can kind of help each other in this way. But the macula densa, particularly acting in this vasoconstrictive measure, is a big difference between them and the granular cells. Okay. So remember, our afferent arteriole detects low blood pressure and releases renin. Renin is actually an enzyme. So it travels through the blood and will catalyze the reaction of angiotensinogen into angiotensin 1. Angiotensinogen is always in circulation. It's made by the liver, so it's always there. And then when renin is present, renin is going to catalyze that conversion of angiotensinogen into angiotensin 1. And then angiotensin 1 is converted into angiotensin 2 by this enzyme called ACE. So ACE is angiotensin converting enzyme. Also always in circulation, produced by the lungs. Okay. Angiotensin 2 is a systemic vasoconstrictor. Okay, and so vasoconstriction will increase blood pressure. So this is a quick way for this renin-angiotensin system to immediately increase blood pressure. And angiotensin 2 also causes the release of aldosterone. So aldosterone is made in the adrenal glands, and aldosterone will also increase blood pressure, mostly for its effects on sodium reabsorption in the kidney. Okay. So remember that it is increasing sodium permeability of the distal convoluted tubule, and that this will increase sodium reabsorption. Water is then going to follow that salt, and so you have an increase in water reabsorption, which together gives you an increase in blood pressure and a decrease in urine volume. Okay. So here's an overview of the system. Renin from the granular cells is going to cause angiotensinogen from the liver to be converted to angiotensin 1. ACE, our ACE enzyme, causes angiotensin 1 to be converted to angiotensin 2. Angiotensin 2 is a systemic vasoconstrictor, and it tells your adrenal glands to release aldosterone, which will increase sodium reabsorption in the kidney to increase blood pressure. Okay. Another way to look at it from your book, so a different view of this too, but again, the end goal being to increase sodium reabsorption, therefore increasing water reabsorption, therefore increasing blood pressure. Okay, so I really encourage you to draw this out, look at it. You can also draw the effects of ADH on this system as well, and think about these things in concert, both for maintaining levels of sodium and water concentrations and for maintaining blood pressure. Okay. So that's a major system that's controlling reabsorption in the kidney. Now we're going to talk a little bit about secretion in the kidney. And remember that we're going to have secretion as movement from the peritubular capillaries to the tubular lumen. So if you want to secrete more stuff, dump more things from the blood into the lumen, now you have a chance to do that. So these are going to be things that are not filtered at the glomerulus. A really important one here in maintaining pH is going to be hydrogen ion secretion. And we also see potassium secretion. Potassium secretion is regulated in the DCT and the collecting duct. And so what happens is that if blood potassium is high, you get increased potassium secretion. So again, this is a way for your body to dump things out, put things from the blood into the urine and get rid of them. This mechanism, this potassium secretion mechanism is coupled to sodium reabsorption. So if we look here in the ascending limb of the loop, and we look at our filtrate, the tubular lumen on the left-hand side, and the interstitial space on the right-hand side, we see a couple things happening, okay? So from the apical membrane, from the filtrate, we have sodium coming back in, being reabsorbed, also potassium, also chloride. But on the bottom, we see there's a potassium transporter that pushes potassium out. Okay, so what's happening there? That's creating that concentration gradient to have a lot of potassium in the filtrate and less potassium in the ascending loop. So then potassium will come down its concentration gradient through the transporter, bringing sodium and chloride with it. And then on the basolateral membrane side, we have a pump. Okay, we've got a pump for pumping sodium into the interstitial space. But look what's happening. You're pumping potassium actually back into the ascending loop. Okay, and so what you do then is that ends up with this net movement of potassium secretion, so into the lumen. Okay, so you're trying to get rid of potassium. Also on the basolateral membrane, there is a potassium chloride cotransporter. Okay, but you note that that one is passive, so that's only going to be happening when you are when you have a high amount of potassium in that ascending loop, and not as much in the interstitial space. Okay, but the goal here is that these mechanisms all together are going to allow you to dump potassium into the filtrate in the lumen. Okay, and the only active part of this is that sodium-potassium transporter on the basolateral membrane. Okay, so review of these things. Our sodium-potassium ATPase reabsorbs sodium and secretes potassium. It's controlled by aldosterone. So when you have high potassium in the blood, it directly stimulates the adrenal cortex to release aldosterone. In addition to secreting potassium, we can also secrete drugs. And essentially, if you think about it, all foreign substances need to be secreted, okay? Because you don't want to be keeping foreign things in your body longer than necessary. So this is one reason why we need to calculate correct dosages for patients. And this is why a pharmacist's job is so important and takes so much training, is that you need to correctly calculate dosage for something to have an effect in someone's body, but also take into account the amount of secretion that's going to be happening from the kidneys. Okay, let's think about an example. You've just gone to a Friday night movie. During the show, you ate a huge bag of salty popcorn with butter and drank an extra large soda. So I want you to describe the changes that are going to occur in the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting duct. And be sure to mention changes in hormones and physiological action. Whenever you're describing this, think about the order things are going to happen and the directionality of these changes. Okay, so we think about consumption of salt and water. In the PCT, we get 65% sodium, water, and 100% of glucose, reabsorption. In the descending loop, we get reabsorption of water. The ascending loop, we get 25% of our sodium pumped for reabsorption, and about 10% of sodium reabsorbed in the DCT. If we have a decrease in aldosterone, it inhibits this, whereas ANF levels or ANP levels would increase to secrete sodium. So you got a lot of different hormones and ways in which to cause sodium reabsorption or sodium secretion. Okay, in the collecting duct, we get a decrease in ADH, decreases water reabsorption. Okay. So this is a review of the setup and concentration, and just also the relationship between the tubules and the blood in the kidney. Okay. So next thing we're going to talk about is plasma clearance. So you get about 125 milliliters of plasma filtered per minute, and 124 of that plasma is reabsorbed. So we reabsorb almost everything, which is a good thing because that way you don't have to drink quite so much water, right? And so this measure of clearance is the volume of plasma completely cleared of a substance. So how are we cleaning or getting rid of something in our plasma? It tells us how much plasma is cleaned and helps evaluate kidney function. So we can start to see decreases in clearance would indicate that somebody is having toxins or other things building up in their blood, and we would need to do something like dialysis or increase kidney function. We measure clearance depending on the substance. So each substance is going to have a different clearance. It's going to depend on how long it takes the kidney to clear that particular substance. Okay. So let's think about this if plasma clearance is equal to GFR. We said that GFR, glomerular filtration rate, is about 125 milliliters per minute. So if a substance is filtered and is not reabsorbed and is not secreted, then it's going to equal this. So we actually measure this with something called inulin. It's a plant carbohydrate, and it's used to measure GFR. We know inulin is filtered, meaning it makes it into the urine, but it's not reabsorbed and not secreted. So it gives us a nice measure of GFR because we're not having to calculate any of the other reabsorption secretion things. Creatinine can also be used this way because it's from a breakdown of creatine phosphate, and again, it's filtered, but it's not reabsorbed and not secreted. If plasma clearance is less than GFR, it means the substance is filtered and the substance is reabsorbed, but it's not secreted. So something like urea from nitrogen waste. Urea clearance is about 75 milliliters per minute. Okay, and so we get some reabsorption of urea. Glucose is also this way. We get glucose clearance of about 0 milliliters per minute. So typically we absorb all of our glucose, right? Unless you're in some kind of diabetic state. That's when we typically see increases in glucose in the urine. If plasma clearance is greater than GFR, that means the substance is filtered and is not reabsorbed and is also secreted. Okay, so again, hydrogen ion clearance is typically higher than GFR, 150 milliliters per minute. Okay, and so we start to think about things like medications for addressing hypertension, high blood pressure. We have to think about all of these mechanisms, right? And so one of the common, or at least the early medications for blood pressure decrease was diuretic. And so some of these actions of diuretics are shown here, okay? So if you want to pee more to get rid of some of that high blood pressure, there's multiple medications that will target these mechanisms. So the top left, we see carbonic anhydrase inhibitors. Those are going to decrease the sodium reabsorption. Okay. Loop diuretics, ones that act in the loop, are going to inhibit sodium reabsorption in the loop. Thiazide diuretics are going to inhibit sodium chloride reabsorption in the DCT. And then we also have potassium-sparing diuretics that are affecting that sodium-potassium pump in the collecting duct. Okay, so again, we're thinking about managing high blood pressure. There's lots of different drugs and medications that can do this at different places, but are going to be affecting different mechanisms. And so certainly we're looking for more consistently because hypertension is a chronic problem. And these can have other side effects as well. Okay, so commonly in use, diuretics are going to be for patients with hypertension, congestive heart failure, or edema. They're going to generally decrease sodium and water reabsorption. And the action can be various places as shown in that previous picture, right? The action can be at the ascending limb of the loop, the DCT, and the collecting duct. And the idea being that if you have a decreased blood volume and an increased urine volume, you're then going to have decreased blood pressure. Okay. Some other diseases to think about are going to be acute renal failure, and this is where you have reduced urine formation. But this is typically reversible. So as long as we can make sure that somebody's blood is being filtered often enough and we can reverse the acute renal failure, then we can have rescue of the kidneys and rescue of blood cleaning. In chronic renal failure, though, we get slow progressive loss of kidney function. And this is particularly dangerous because it's often 75% of destruction before it's noticed. So this can happen, and by the time you get to noticing it, it can be really catastrophic. When you get to end-stage renal failure, so 90% of kidney function is lost, this requires dialysis and kidney transplant. And now you know how often and how much you're filtering all the compounds in your blood into the kidneys. And so you can imagine then if you have no kidney function, you're going to require pretty much constant dialysis. Another one that comes up for renal diseases is going to be glomerulonephritis, and this is an autoimmune disease which causes inflammation of the glomerulus, and it's diagnosed by proteinuria. So remember in our lab, we looked at proteins in the urine, and most people are not going to be having high levels of protein in the urine. So if you do, or somebody does, proteinuria is there, and this can be one cause of it too, okay? So it's one way to catch glomerulonephritis is by looking at proteins in the urine. And that's it for today. So I will see you all next time.